This is Mrs. Lewicki, and this is part 4 of the Shock PowerPoints. This is the final in the series, and I do want you to know that this one's going to talk about the rest of the clinical manifestations of septic shock and then some of the nursing interventions. Clinical manifestations include thrombosis of small vessels, extreme tissue hypoxia, you get peripheral vasoconstriction. There's an increased lactic acid production because of anaerobic metabolism, and that leads to cell death, which then can lead to brain anoxia and brain cell death. All systems are starting to decompensate. Patients unconscious and unresponsive to stimuli, reflexes are absent, systolic blood pressure is falling, and there's no response to treatment. Heart rate slows, the pulse is weak and thready, and a pulse deficit is apparent. Dysrhythmias from ischemia to the myocardium occur, increase in potassium levels because of cell death. Slow, shallow respirations with irregular rate and rhythm, or we call that Cheyne-Stokes. Cyanosis, dusky blue to purple color, and the skin is cool and clammy. Diagnostics tests, you can see there's a lot on here. We're going to want to make sure that we do a serum lactic acid. I'm not going to talk about all of the other ones. We are going to, another one that's not listed here is we would probably do blood gas on the central line so that we're looking at an SVO2, and what we're trying to determine is whether tissue hypoxia has occurred and whether our treatments are working. And I'll show you a video in class that we talk about it. I also want to talk about blood cultures. Remember that blood cultures, there's a process to collecting blood cultures. And usually they're not done by the nurse. They are done by the lab because there's a specific scrubbing process they have to do. I want to get blood cultures, usually 2 sets, 30 minutes apart from 2 different sites. And those have to be done within an hour of the diagnosis of sepsis. Um, Nursing interventions from a neurological perspective, I'm going to be doing probably hourly neuro assessments, focusing on their orientation and level of consciousness. And if it's neurogenic shock, then I want to stabilize their spine and ensure that I do things like log rolling and keep that spine stable. Cardiac, the patient will be monitored. If they're in ICU, they'll be on the cardiac monitor, and likely they'll be in ICU. I'm going to do vital signs minimum every hour, sometimes every 15 minutes. I'm going to assess capillary refill. If for cardiogenic shock or even septic shock, they may put in a pulmonary artery catheter, and then my job is then to monitor that and make sure that, and Swan-Ganz is the other name for pulmonary artery catheter, and I'm going to monitor those readings. Respiratory, likely they will get intubated and ventilated, but I'm going to monitor their respiratory rate, their rhythm of their respirations, and monitor their O2 sat as well as how much oxygen they're requiring. GU, I'm going to make sure they'll likely have a Foley. We're going to do strict intake and output, and I'm going to report the urine output of less than 30 mils per hour for 2 consecutive hours. This should be GI. I'm going to make sure that I assess their bowel sounds. They may have an NG tube, so I'm going to hook that up to low intermittent suction. Patients in shock have a high metabolic rate, so feeding should be started as soon as possible once bowel sounds are present. And if we're not able to start tube feeding, then we want to consider doing TPN. Prophylactic PPI, proton pump inhibitor, usually that's Protonix. Once bowel sounds return tube feeding, we're going to do Accu-Checks every 6 hours because what happens in shock is they become very hyperglycemic as the sympathetic nervous system is causing glycogenolysis by the liver. And so their blood sugars go up and up and up and up. And so they're probably going to need to be on some kind of insulin infusion. And I'm going to want to make sure I do oral care regularly. Nursing integumentary skin assessment. I'm feeling for the temperature. I'm looking for pallor, flushing, diaphoresis, and cyanosis. I'm going to make sure I turn them every 2 hours. Make sure I put on SCDs, which suddenly have compression devices. I can't remember what the S stands for. Sequential compression devices on their legs. Again, we're going to do oral care and neurogenic shock. Again, I need to control the room temperature. And I want to have early IV access in all shock patients. So if they only have peripheral IVs, they're going to have a couple of peripheral IVs. And when possible, I want to get a PICC line placed or a central line placed. And that's the end of the shock PowerPoints.